and we've been talking to scrutiny officers across the whole of the catchment. There are around about 13 scrutiny committees to consider the option of a joint scrutiny committee to oversee that process. So my reason for coming to you tonight is really twofold. One is a simple update on where we're going, an opportunity to discuss it and try and answer some questions. And the other is really to ask you about your involvement in the process going forward, rather than making assumptions. Obviously, Luton and Dunstable Hospital is one of the site options for the radiotherapy unit, and the intention is to consult on that as an option. I'll stop talking now and wait to see if you've got any questions, anything that I can answer or clarify.
Thank you. Does anyone have any questions? Councillor Chowdhury.
It's not really a question. I'd just like to say, I mean, radiotherapy centre in Luton is, is very desirable. I see we have a high number of people going for cancer treatment. And can we get, I mean, how do we get involved in those discussions? I would like to know more about that if possible.
Okay, thank you for that question. I think we are in the process of developing a consultation plan to make sure that local stakeholders and local residents can have their say. So we have some criteria that we are proposing to use to make the decision on which site the radiotherapy unit would be based on. Some of those criteria are what you would expect around can they meet the national standards? Can they do they have the right services on those hospital sites to support the network radiotherapy? But we also have some criteria in there around reducing inequalities and patient access and patient experience. So my advice to all areas, and obviously we have to run an impartial consultation, but my advice to all areas is to get involved in the consultation and to look at the questions and to really provide to give views and encourage your residents, encourage patients in your wards, in your town, to really get involved and respond, because I think it's understanding the impact of the different options on local people that will really help us make the decision as to where is the right place to put this.
When you go out to consultation, I mean, how would that be made available to people?
So we are still developing the plan at the moment. So I'll run through roughly sort of high level what it is. But actually, we're really wanting to have feedback from local communities about how they want us to consult with them as well. So we will have the standard things that we have to produce, or a consultation document, an easy read version. We'll have online, we'll have hard copies. We'll have the promise of translation into different languages. I'd like to do an audio recording. We're hoping to make some videos that explain what we're proposing, so that for people who are a bit more visual, who don't like reading big documents, that there's something that they can watch perhaps. And then we'll have a number of events and roadshows. Hope to do some face-to-face events in Luton and in other areas as well, where people will be able to come and have their say and ask questions. We also want to come and talk to patient groups and residents groups, so we'll be asking people to invite us along, and we'll try and prioritise coming and speaking at those events and answering questions, and in helping people really respond to the consultation. Each area is very different, so and it's a big geography that we're consulting over. So rather than have one consultation plan, we're having sort of an overall consultation plan, but then we're having a separate plan for the east of England, a separate plan for London, and a separate plan for the southeast areas, so that we can involve people who know those areas best in making those plans for that area. So we have people from BLMK, ICB, and we will have from the local authority as well, getting involved in helping advise us and steering how that plan develops.
Thank you. Councillor Mead.
Thank you, Chair. As though I'd love to see new facilities treatments being available at the Luton and Dunstable, as somebody who uses it reasonably regularly for checks and things, one of the biggest issues there is parking. And if we're going to bring in regional services, I don't think we can look at it in isolation. We've got to think of that parking issue and making sure that people, when they do come from outside Luton, can park easily and quickly when they visit the hospital, because at the moment it can be a nightmare.
Yes, parking's been one of the issues that's come up a lot through a lot of the engagement we've done over the last few years. And it's certainly something that's a consideration. As I say, one of the criteria around access, that will include looking at parking and so on. And that's not just about which site has got the best parking, but it's what can we do about parking as well. So it's certainly something that's on our radar to really look into and help people get to the hospital, particularly for something like radiotherapy, when we know that most people drive or are driven. We also have in Luton a pilot that is running with the ICB around transport to hospital for cancer treatment, and that is transport both to Luton Dunstable Hospital and to Mount Vernon. That's in its early stages, but we will be doing an evaluation of that and seeing if there's anything that we can learn from that and roll that out so that helps people get to their hospital appointments. In particular, thinking about people who don't have a car, don't have access to transport, and where public transport isn't necessarily the right mode of transport for the state of their health and the condition that they're in.
Thank you. I've got a couple of questions about the when the funding is secured, about the transition. One of the things that came up in the survey was patients would like to see that the staff that are presently providing the service carry on with the new service. Is that going to be possible with a new supplier taking over from the East and North Hospital Trust?
Yes, so our plan is, or our proposals are to build a new cancer centre at the Watford site, but transfer the management of the site to UCLH. That was one of the recommendations of the original panel that came in and had a look, because they recommended that we transfer the management to a specialist cancer centre. Now, that specialist cancer centre will want to retain the local expertise and the local skills. It's not a service where there are huge numbers of people, you know, for every job. It's something where we really want to retain the services, and that's been one of the other reasons why it's really important that we do move ahead to consultation. We do make some decisions because the staff need to know what their future is, and at the moment it's very, very uncertain for them, and so we have more of a risk of losing staff now than we do once we've got a future planned. And the idea of the transfer of the management is that it's just that, it's the management of the service, the assumption at this stage would be that there would be what's called a TUPE process, where staff would transfer to the new employer. So their jobs would stay the same, their contracts would stay the same, the people who pay them would be a different trust. So yes, we wouldn't anticipate a whole load of new staff coming in. We think this will best facilitate keeping the staff groups together. The network radiotherapy unit would be staffed by the same team coming out to the radiotherapy unit, and we've been working with the staff, with the clinicians, and developing the proposals. And again, this is something that they're quite comfortable with the proposals and quite excited about the potential for the new cancer centre.
Okay, thank you. Actually, I think that's about it for me. If no one else has any other questions, I think we are. So I recommended to note the progress of the plans to move forward to consultation. think we've asked questions about that, so I think that's okay. We're also asked to consider how we wish to be involved in the process, or whether we wish to participate in the Joint Health Overview and Scrutiny Committee later this year. And I get the feeling that we would like to be involved in that. So perhaps we need to have a discussion with our democratic services and to get back to you with our with the results of those discussions, if that's okay.
Yeah, that'd be great. Thank you.
Okay, so okay, we look forward to seeing the plans for the consultation. Thanks very much, Jessamy. Thank you.
Thank you. Thanks for having me.
Okay, moving on to item 10, the new health practices update. Emily?
Thank you. So we brought a paper to this committee in October of last year when we were in the process of mobilising a new contract, and I think you asked us to come back with a bit of an update as to how things were progressing. So the paper sets it out, and I'll run through picking out a few key points that probably line quite nicely with the other agenda items today. So we mobilised the contract on the 1st of October. It's a form of contract which isn't run by GP partners. It can be provided by large organisations such as East London Foundation Trust. So we won the contract in October, and it's a contract that will run for 5 years initially, and then there'll be further conversations about that. It brought together 2 existing GP practices, so Kingsway Practice and Birmingham Park Medical Centre, which you may know are quite different in terms of their patient populations and how they were working. So in terms of the actual contract mobilisation, it really went quite well. All the clinical and admin staff who were working in the 2 practices to be transferred into ELF. So the previous speaker talked about people moving into the organisation under the same terms and conditions. So they all joined us and were able to provide really good continuity. So we haven't lost any of the clinical staff members or any of the admin team members through that process. Nobody was made redundant, and the majority of staff, when we went through a consultation process to move on to NHS terms and conditions that we use, benefited from a pay uplift. So there are more favourable conditions now than there were previously. There are a few exceptions to that who chose not to apply for roles that had, or not to kind of slot into roles that were slightly more advanced and more senior than they were working at, and they're on pay protection, so they're not being disadvantaged. That is time limited. But the key thing is we sustain clinical continuity. The GPs remain in the practice, the other clinical staff remain in the practice, as do the majority of the admin staff. I mentioned the pay award and uplifts because staff morale is really important, particularly in primary care. Colleagues have spoken about how challenging it is being confronted by reception staff who are unhappy, who are rude and not compassionate when speaking with patients, and often that's a consequence of low staff morale, that they're not working in a way that they feel respected or they feel appreciated. And not that anybody should ever be rude to a patient, but some of those roles are quite challenging when you are speaking with a number of people, many of whom are justifiably quite frustrated that they're not getting the care or service that they're seeking. So looking after staff morale is absolutely crucial. We've done a piece of work around recruiting some new staff members as well. So Nikki mentioned the importance of modern primary care and having different roles that work alongside the GP. So if you call in to see somebody, you might be seen by a very experienced clinical pharmacist who can prescribe in the practice. So we've recruited for clinical pharmacy and additional pharmacy techs and paramedics as well. So paramedics will often do things like minor illnesses. If you're feeling poorly, you might see a paramedic in the first instance if it's quite likely you have something that needs seeing to, but isn't a particularly complex condition. They can prescribe, for example, so if it's urinary tract infection, you might see a paramedic instead. So really trying to make sure we have a diverse primary care workforce within the practices. We've done lots of work around merging the system. So Nikki's spoken before about there being GP lists, and there were 2 separate case recording systems, and we pulled them all together into one new consolidated case recording system. So it doesn't matter whether you are originally a Kingsway patient or a Birmingham patient, all the patients are now kind of contained in one practice list because these two sites are working as one practice, or at least that's what we're working towards. It is a bit of a journey. We've changed the practice name. So we worked with our patient participation group, and we've done lots of work with our PPGs as well. Birmingham had quite a robust PPG. The one at Kingsway practice wasn't as well attended. So we brought those together and done lots of work around things like setting terms of reference, codes of conduct. People are really clear what the role of the PPG is. That is to be that critical friend and to give feedback about things that are affecting patients, bringing your own story, but also thinking about how you work to represent your whole population. So working really closely with our PPG to make sure that they were involved. And we put the names to a vote, and the name that won was, excuse me, the slightly uncreative, but familiar, Kingsway and Birmingham Medical Centre. So that's what we've gone with, and that you'll see on our website and things now. We've also done lots of work around mock CQC inspections, so doing a bit of an audit of the practice in some detail to identify if there are any areas of concern and make sure that they're improving how things are working. Excuse me. Sorry. It hasn't all been smooth sailing. I would be lying to you if I'd said that everything was going perfectly well. But actually none of what's come up since we've taken over the practices is terribly surprising. So we pulled together two very different practices with very different ways of working, even though they were run by the same provider previously. And we've now got these two very different practices coming together with a new organization. So it's unsurprising there are a few bumps along the way in terms of people feeling like the thing they really valued has been lost, and missing the way they used to work. So we've done lots of work with organizational development. So specialists who work with our teams think about what they have in common, what their purpose is, and how we can make sure that actually people are working with a new culture, and a culture that reflects ELF values. And I think it's fair to say ELF values and Luton values are very kind of closely aligned in terms of trying to make sure we are offering a really equitable service and addressing inequalities. But it has been a little bit bumpy. So we've had some challenges in terms of our workflow processes, and people doing things in a very different way has led to a few backlogs in terms of some clinical documentation and referral processes. So what we've done is we put in extra capacity from our other clinical services. We run GP practices elsewhere in Bedford, Luton and Milton Keynes. So we brought in expert capacity there to make sure that actually we can get systems and processes working really effectively and really smoothly, and that we can identify any training gaps that we might have not been aware of previously. And also putting in additional clinical capacity. So we have additional GPs who work with the practice on a locum basis at the moment, just making sure we have enough kind of eyes on anything that might be going wrong. We've also got our practice senior leadership team, myself, my medical director colleagues, and my head of nursing going into practice on a regular basis and meeting with them weekly, just to make sure they're feeling well supported and that we are not going to discover anything or miss anything that could be concerning for patients. So as I mentioned, we have noticed some skills gaps as we've gone through the system merger journey, and we've done a bit of we're going through a structured skills audit so we can identify what the specific training needs are for staff, and that's the practice-based admin staff, but also the kind of leadership team. So we can think about leadership development, because again, that workforce morale, that working in a really compassionate way to reflect the needs of the community is absolutely important and relies on really robust leadership. We've been able to pull in some quality improvement work as well. So I'll come on to that in a moment. But just to note that the patient experience matters that we were talking about previously. So Nikki mentioned the patient experience survey has come out. Unfortunately, the Kingsway and Birmingham response has been disappointing. Again, I'd say there isn't stuff in there that we weren't working on already and expecting, but it's unsurprising that patients who have had difficulty kind of making contact and getting appointments in the way that they need to has come out in the patient survey. So regrettably, we are quite low in terms of the number of people recommending this practice as good, but we have a number of actions in place to address that. So Nikki's spoken about things like care coordination. So it's really, really important that all our practice staff have refresher training in terms of care navigation, and that means making use of the appointments that are available for things like first contact physiotherapy, the other services that are provided by the primary care network. So we have physiotherapists, clinical pharmacists, physicians associates, a number of different roles that can be and appointments that can be offered to patients, and also making use of things like pharmacy first. If somebody does call in and there isn't an appointment available, the patient isn't let down. They do have some information, advice about where to go, but also that we're making really good use of our appointments. So we're not offering, as Nikki said, all our appointments to the first few callers without having any kind of sense of the person further down the line might be your sister and her daughter who've got significant needs. So being really, really thoughtful about how we're using our capacity and making sure our staff are well trained to do that, because it is going to mean, or it does mean, not always saying yes to patients who are calling and asking for an appointment. So it's a complex conversation, but they need to be polite and respectful and able to have that in a fairly sophisticated way. We have introduced a new cloud telephony as well, which is the new phone system, which as Nikki says, means that if you make a phone call, you know where you are in the queue, and you also have the option to kind of request a call back. So you don't, if it says you're going to be 45 minutes on the phone, you can press a button, and then when your turn, you don't lose your place. So you keep your place in the queue, and then when you get to the top of the queue, the practice, it'll like connect you, it'll phone you back basically. So you can go and make a cup of tea, do what you need to do, as long as you keep your phone nearby you. That system means that you won't kind of miss your slot in what I admit are still quite long lines first thing in the morning. We're doing lots of work to try and address a number of the issues that have come up in terms of inequalities. So we have a quality improvement piece of work going on, which is looking at why people don't come to health appointments, why they don't come for their cervical screening, why they don't come for their health checks, and trying to understand with our local populations what some of the barriers are. The ones you've picked up so far are around digital literacy and digital exclusion. So you mentioned people not having phones and not liking using technology, but also with a number of people who don't have great health literacy. So it's being able to navigate and understand how the NHS works and how you make an appointment and who you call. Our intention is to do some outreach work into like local mosques and the community settings and create some very, very simple kind of YouTube style videos in multiple different languages that are relevant to the local population. So people aren't reliant on written text for information. There is a digital element, I admit, but it's just a different way of kind of sharing information from a patient perspective, co-produced with local people about why coming to these appointments is important. So why is it important to come for a cervical screening appointment? Why should you come for your 40+ health check? But doing those co-produced with patients so they are familiar, engaging, and that's being led by our head of nursing. As I mentioned, we're doing lots of, our workforce is absolutely crucial. So we have got some work to do, and I really hope that nobody's had a kind of challenging experience with any of our reception staff. We are being very thoughtful about the training we're offering them in terms of things like care navigation, but also customer service and de-escalation skills. As I said, it's never acceptable to be rude to a patient or anybody calling in, but sometimes emotions run high and you need to have skilled conversations about taking the heat out and making sure people get the services they need. And we're putting on training for staff on that. We're also working, took some notes on, I can't do my handwriting now. We're also trying to work to make sure we're putting together the services that we offer as ELF. So East London Foundation Trust is a big organisation and they do provide local mental health services. And we have got good relations with other community partners. What we're trying to do is to use these practices as a way of kind of making sure we're forming really good relationships with with ourselves, basically, because the services don't necessarily line up well or talk to each other a lot. So making sure that we as ELFT can line our primary care services with our mental health services and with other partners so people do get a good integrated offer and you don't get bounced around the system. It is a work in progress. At the moment, we're forming relationships and making sure that we have like a really good set of data so we can understand where the patient's needs are from within our practice population. But that I think is one of the key benefits to having ELF as a provider of primary care. So whilst it's not necessarily been smooth sailing, We have a really clear plan in terms of how we're going to carry on improving the practice. So we'll see much better patient experience results over the next when the survey is next completed, but also actually doing something slightly more strategic in terms of how we use our capacity. The thing I was going to say in terms of the patient surveys that we do keep an eye on other metrics as well. So we have regular surveys that go out to patients at the end of an appointment that we look at as a leadership team on a monthly basis. So patient feedback that is more timely, really. So monthly basis, and also assessing things like any complaints that do come through. So we have a really clear sense of where things are not going well and putting in specific plans to address that. So the reception staff thing is something that has come up with particular team members, and we are tackling that. I think that's probably all from me, but thank you very much for letting us come back and speak with you again. And I'm confident that even though it's heading in the right direction, as I said, I don't think there are problems we don't know about that we're not tackling. But I'm happy to be told otherwise, and if there are, we'll go and sort them out.
Okay, thank you. Okay, does anyone have any? Yes, Councillor Nessa.
Thank you, Chair. Thank you, Emily. You actually explained very in depth and clearly. My question, I mean, I had many questions, but you already answered that. But I've got two questions, which we asked that last year, October, when we agreed here. So the same question, I just want to know, whether how far this has, have you monitored them? So the question we had that time about homelessness, people who doesn't have a contact details, who are homeless. And one of your colleagues that did elaborate that there will be a facility in Kingsway. The people are homeless, they can come and see the doctor easily, which we was having problem to get them in other areas. So I want to know whether, have you seen anything on that? And my second question is, we did raise concern about Kingsway that time. That was in highly concerned place about the reception behavior, which my colleagues also did ask that question before. So, I mean, you already said there was a lot of training has been done, but have you monitored that? Has that been improved by that 1 year? Thank you.
Thank you. So unfortunately, I haven't got a response on the homelessness question, but I will go away and look at that. We run specialist inclusion health practices in inner London, so practices that are specifically for patients who are homeless. We find most people have got phone numbers, but addresses obviously vary hugely, and also our homeless population in inner London certainly change their mobile phone numbers quite frequently. So I don't have an answer for that. Don't have an answer on that question for you, but I'm very happy to go away and find one out. What I would note is that we are trying to get all of our practices signed up to be, and I'm going to get the name wrong, but there is a scheme that is a Safer Surgeries accreditation, which is basically that your practice is welcoming and accommodating for people who are homeless or refugees and asylum seekers. And it goes to good steps to try and kind of make it a pleasant experience and an accessible service, because often people have more than just challenges of engaging because you haven't got an address and haven't got a phone number. There are other significant barriers like power dynamics and practices, surgeries and NHS institutions feeling quite authoritative, and that being something that people who are street homeless often have had very negative experiences with. So I can assure you we're doing a piece of work across all of our teams in the directorate to make sure that they meet Safer Surgery. I'm going to get them. I keep there. Safer Surgery standards, but I don't know specifically for Kingsway, and I can go away and look into that. And in terms of the practice staff attitude and response, it is something that we're keeping a close eye on. We are mostly looking at it through complaints coming through and kind of feedback we're getting, but we have got the ability through the call system that we're now using, the cloud telephony thing, which allows you to kind of listen back and audit phone calls. So if somebody says, actually, had like a really difficult encounter with the receptionist, previously it would have been a bit, well, he said, she said, and quite difficult to kind of understand. We now have the technology that allows us to do a bit more robust assessment of actually what happened. and understand those situations in a bit more detail. So I wouldn't say we're monitoring it in terms of spot checking phone calls, but we are responding when complaints come through, and that is one way we can look at it. We're also asking staff to hold each other to account a bit more. Some of the organizational development work we're talking about is about actually, if we want these surgeries to work, the practice staff need to kind of own them, feel accountable for them, like be proud of the work they're doing, and be proud of Kingsway and Birmingham as a unit, rather than I'm a Kingsway girl, I'm a Birmingham guy, and actually I don't really want to kind of be part of this new thing, which is a reality of how some people really feel about it. So it's an ongoing process. I wouldn't say we've got it there yet, but if you have any complaints, please do let me know.
Thank you.
Okay. Thank you, Councillor Chowdhury.
Oh, thank you for your report. It's given me confidence to go back and make an appointment to see my doctor.
I hope they're doing. The other thing I should say that we are introducing, so it's not available just yet, and it is something that's technologically enabled, so it won't be for everybody, but we are going to be using a thing called eConsult, or one of the other versions of it, which allows you to kind of enter your symptoms, and it'll kind of give you a bit of advice for whether you need to kind of see your GP, or whether actually you should go see a pharmacist. So some of the care navigation stuff will be done through that process. But the most important thing is that we have a really needs-led approach for allocating appointments. So we don't kind of give all the appointments to the folks who phone in, all the appointments to the folks who kind of send the e-consult form, that we do triage, as Nikki said, to make sure we're using our limited capacity as best we can, because I don't foresee, even with the new government, there being a situation where we have as much GP and primary care capacity as we would like or as we need. So it's always going to be a balance in terms of how we make sure that people with greatest need are the ones who are able to kind of access appointments as a priority.
Okay. Thank you. I just have a general question for yourself, and probably for Nikki as well. The cloud telephony system, is that so does that have the potential for reducing the is that the sort of thing that reduces the potential for the confrontational situations that you sometimes get between the first point of contact and patients?
I would hope so, and that would help manage expectations. So you're not sitting on the phone for like 2 hours and not knowing that you're going to be there for a long time. I exaggerate. It does kind of bring awareness to how long you're waiting and who's ahead of you in the queue. I wouldn't say it's necessarily problem free, although I have to admit, the things I hear about are when it's gone wrong, rather than actually the like 99% of the time when actually it's working really helpfully. So there have been occasions when the callback system hasn't worked because the person's mobile phone has dropped signal. So the surgery, the phone system has tried to make contact with the patient, but for reasons within the kind of patient's IT provider or patient's line, the calls dropped, because these calls don't drop, they're all cloud, and they have like super backup systems, and they won't, the internet connection won't die on them. But few of us have those sort of phone systems in our own homes. So there have been problems where it hasn't necessarily pulled the call through, and the person's been understandably quite frustrated. And we've had to do some work to make sure that the phone rings for a certain number of time before it disconnects. So again, people missing the call back because they weren't expecting it, or they were away from their phone and haven't got a chance to get to it quickly enough. So there are a few things which are grumbles, but I would say that there are the grumbles. I hear about the things that go wrong. I don't hear about the majority of things that go right. So it should help, and I think it will help us it'll give us lots of data. That does give us data, and that helps us plan and manage and kind of self-assess and review as well to improve.
I think it's important that the 23 practices have all been funded to put it in. So cloud-based telephony is in all now 23. I think the other important point to raise is that you need the staff skilled up to use the kit and technology, so that and a little bit of what Emily was saying on that front. I think the only other point for us all to be aware of, it integrates into the actual computer system, whereas previously you had a telephone system that wasn't connected to computer. So the point is it's all connected, hence why you start having some rich information, which helps the practices. And then I think finally the point to raise is previously where it felt as though no one was answering, I explained that a lot of the time if the lines were too busy, the practice staff wouldn't have even known that you'd rung because it would just ring out on the switchboard. So it is a massive game changer. And if you look at the national models, the impact of patient responses to are you happier, they are. So we watch that space and it has shown a bit of an impact in Luton already.
Thank you. Yeah, that's encouraging. Thanks, Emily. Thanks for a very detailed and very honest report, I think. I think I'm not sure if we necessarily need you to definitely come back and report. I guess if anything does go wrong, then that perhaps might be the time to come back. Hopefully not. Yeah, I think it. Sorry, Nikki. Yeah.
I have to say, having Emily tonight was actually incredibly helpful because there is something about close to the service, and I noted on the updates. I do wonder if there is something we could do with perhaps bringing a clinician, giving a perspective from a practice manager or a perspective from a care navigator. It may just give this evidence. I'm not going to come up with any major changes month on month, but it could be we have a lens about how we work together, because what's very, very clear is that we've got to work together to help people to understand what the offer is. And equally, we do get quite a lot of pushback when people think you're being palmed off and you're not getting something as good as a GP. So just a thought for you to consider, Chair.
Okay, should we take that discussion offline to finalise that? Yeah, thank you. Okay, if that's everything, move on to the final item 11, draft work programme reports. Quick look at that. So we have a very busy, potentially very busy meeting on the 17th of September. So perhaps need to have a discussion with Democratic Services about perhaps reorganising or seeing if anything can be put back. Does anyone have any items that they would like to? Okay, I think. Oh, sorry, Councillor Rice.
Sorry, I was just going to say, because these are quite full subjects, so perhaps maybe it's just condensed a bit. Otherwise, we'll be here for a very long time.
Yeah, I appreciate that. So yeah, we'll have a discussion about that. Sally.
I've just spotted that there's the maternity pathways and inequalities update due. I'm not sure we'll be ready in September. We can have a conversation offline, but that might need to come at a later meeting.
Okay, thank you. Yep, I'll note that. Okay, if that's it, then I'll draw the meeting to a close. Thank you, everyone. Thank you for attending and reporting, and have a good evening.